Welcome back to The Explainer. Grab your CPT code books because today we're diving deep into the foundational guidelines of the musculoskeletal system. If you've spent literally any time at all reviewing the 20,000 series codes, you already know it can feel like a total maze. But don't worry, we're going to clear that path today and build you a rock-solid toolkit so you can navigate these rules with absolute confidence. Let's get into it. Okay, look at this quote right here. This counterintuitive rule is absolutely the secret sauce to mastering orthopedic coding. The CPT guidelines explicitly tell us there's zero coding correlation between the type of fracture and the type of treatment provided. I know, right? You'd naturally assume a terrible open compound fracture automatically needs an open treatment code. But as we're going to see today, making assumptions based on the injury rather than what the surgeon actually did will lead to some massive coding errors.
Here is our roadmap for today. We're covering the anatomical foundation, general musculoskeletal guidelines, decoding fracture treatments, understanding external fixation, tumor excision, and finally, some special coding rules. All right, let's kick things off with Section 1, the anatomical foundation.
You simply can't code what you can't navigate. This macro view of the skeletal system anchors all our overarching CPT headings, giving us a really solid big picture of the human frame. When you're flipping through the musculoskeletal section, you'll notice it generally flows head to toe. So starting from the skull and mandible, down the cervical vertebrae, through the humerus and radius, and all the way down to the femur, tibia, and feet. Having this high-level map locked in your brain helps you instantly jump to the right subsection.
But of course, we also need that micro-level detail. Check out the hand and foot anatomy here. You can see the incredibly complex flexor tendons, the lumbrical muscles, and all those tiny, precise carpal and tarsal bones. Orthopedics isn't just about the big limbs, right? When your surgeon is performing a tendon transfer, a capsulotomy, or releasing a contracture, you absolutely need this level of visual understanding to pinpoint those highly specific excision and repair codes. It's like a giant puzzle, and you need to know exactly which digit and structure you're looking at.
Moving right along to Section 2, Musculoskeletal General Guidelines.
Now that we've got our map, let's lay down some ground rules, especially when it comes to stabilization. The absolute most crucial thing to remember here is this. A temporary splint applied just to keep the patient comfortable, that doesn't actually count as a fracture treatment code. If someone rolls into the ER with a broken wrist and the staff throws a splint on it just to hold it steady until ortho sees them in the morning, you do not code that as a closed treatment of a fracture. It's strictly temporary stabilization for comfort. But when casts and splints actually are the definitive treatment, you've got to keep these rules top of mind. The initial application and the eventual removal, those are completely bundled into the first cast. Don't code them separately. However, here's where you can catch some missing revenue. Subsequent replacements during the global period can actually be reported separately. Oh, and one more thing, applying a cast or splint is not considered part of preoperative care, so trying to slap a modifier 56 on there for pre-op management, definitely a no-go.
Which brings us to Section 3, decoding fracture treatments. This is really the meat of our explainer. Let's start by defining closed treatment. The core definition here is that the fracture site is not surgically opened. It's not exposed to the external environment, and the surgeon isn't looking directly at the bone. Remember that hook from earlier? If a patient has a nasty compound fracture where the bone tore right through the skin, but the doctor decides not to surgically open the site any further to fix it, guess what? It is still coded as a closed treatment. It doesn't matter that the bone physically broke the skin. It's all about the surgeon's approach. Okay, so what about the middle ground? That's percutaneous skeletal fixation. This is a treatment that isn't really open, but it's not totally closed either. In this situation, the surgeon is placing hardware, like pins or screws, directly across the fracture site to hold everything together, and they're usually doing this with X-ray or imaging guidance. So they aren't doing a massive open surgical exposure, but they are absolutely inserting hardware through the skin and right into that bone. And finally, we have open treatment. This one's pretty straightforward. It means the surgeon fully opened the site surgically to expose the fracture. But you have to watch for a couple of tricky nuances here. It also counts as open treatment if the surgeon is working directly through a massive traumatic wound to fix the bone, or if they place an internal fixation device, like an intramedullary nail, through a remote surgical exposure that's actually away from the main fracture site. All right, let's move to Section 4, understanding external fixation.
Beyond treating the actual break, we often have to code the hardware that's holding it all together on the outside of the body. There's a really clear distinction to make here between the two main types. Uniplanar external fixation means the pins are placed in roughly the same flat plane. Just picture a straightforward single row of pins sticking out of a leg. Multiplanar external fixation, on the other hand, is a whole different beast. It's much more complex, using transosseous wires and threaded pins placed across several different planes, usually held together by these interconnected rings. Knowing exactly what the hardware looks like is absolutely key to grabbing the right code.
Next up is Section 5, Excision of Tumors. Let's shift gears a bit. If you code for soft tissue connective tumor excisions, this 3-step formula is going to be your new best friend. Step 1, take the tumor's greatest diameter. Step 2, add the narrowest margin of normal tissue that the surgeon required to completely excise it. Step 3, that combined measurement, taken at the time of the excision, is what dictates your code. You can't just wait and look at the pathology report later. You literally need the physician's intraoperative measurements of the tumor plus those margins to code this correctly.
Oh, and here's a pro tip so you don't leave any money on the table. The guidelines clearly state that appreciable vessel exploration or neuroplasty should be reported separately. Think about it. If a surgeon is removing a large, complex tumor and has to spend a ton of time exploring blood vessels or freeing up nerves so they aren't damaged, that is a lot of distinct extra work. You absolutely must report those exploration codes on top of the tumor excision.
Let's wrap up our toolkit with Section 6, Special Coding Rules. We need to talk about some highly audited rules regarding spinal surgeries. When two primary surgeons tackle a massive, complex spine case together, they're acting as co-surgeons. In these situations, you use modifier 62 on the primary procedure code. You also append it to any associated add-on codes if both surgeons are continuing to work together on those extra segments. But, and this is a huge but, pay close attention to this exception. You never append modifier 62 to the bone graft codes, and you never append it to the spinal instrumentation codes. No exceptions. You can actually see these explicit co-surgeon instructions printed right here in the text of the spine guidelines, just before the arthrodesis codes. It lays it all out. The rules even give you clear examples of how Surgeon A and Surgeon B should code their respective parts of the surgery. So always rely on these detailed section guidelines to make sure neither surgeon accidentally miscodes their distinct operative work during a complex fusion. As we wrap up this explainer, I want to leave you with one final provocative question. Every time you open that book, ask yourself, are you coding the injury or are you coding the treatment? Always answer this before you select a CPT code in the musculoskeletal section. Because as we've seen today, whether it's choosing between open and closed fracture care, temporary splinting versus definitive casting, or figuring out tumor margins, the specific treatment method chosen by the surgeon is what dictates the rules. Master the treatment guidelines, and you, my friend, will master the codebook. See you next time.